Good morning, Milind.
Good morning, sir.
Srija has joined.
No, sir, she hasn't joined. I'll just contact her.
Okay.
Sir, hello.
Yes.
Sir, she's joining, I think, sir.
Okay. Actually, I forgot to send the link to Dr. Das yesterday. Chalo, you can continue, no problem. एक बार सोमेन सा का रिंग कर दो एक बार
Hello.
एक बार सोमेन सा का रिंग कर दो
हाँ, sir.
Milind,
Yes, sir.
she has sent a message that she missed a presentation. So start with you.
Sir,
You are prepared. You can start with you.
sir, I'm actually, sir, I'm not in station, sir, actually.
Oh, that's
Yes, sir.
So this should be prepared. No, one class given in a month. Why people should not take care?
Yes, sir. So-
So then you have to call off the class today.
Sir, Somen sir has also joined.
Uh, we can start. I feel. We can discuss the. Showman sir has joined.
Yes, sir.
Sir,
Srija, you have joined.
yes, sir. Sir, I'm extremely sorry, sir. Sir, I missed my date and my presentation is not
Okay,
ready.
no problem. You see, you need not to present. This is in operative. What we do is you don't get a presentation from the candidate. What is an exam scenario? We'll give the scenario, the operative, and we can just keep on discussing how do you do the steps as you said in the exam, because our operative is not presentation. So
Okay,
have
sir.
you seen APR? You have seen APR in your tenure of 2 years?
No, sir, I haven't seen it.
You have not seen. You have read it.
Once, I have read once.
We can discuss why call of the class. We can discuss, and then we can help out. Okay, we can
Yes, sir.
discuss the indications, then steps. So you try to answer. Otherwise, we'll keep on discussing.
Okay, sir.
Okay.
Okay, sir.
Okay. You see, abdominal dissection. We first discuss the open, and then
Yes,
if time permits, we'll go to the laparoscopic part.
Yes,
Otherwise,
sir.
first discuss the open abdominoperineal dissection. Okay.
Yes, sir.
Dr. Das has joined. Dr. Shomen Das has joined.
Yes, sir.
Oh, actually, the candidate is not prepared well. She said she missed the date, but he said we can just discuss. She has
Yes,
read
yes.
one. Okay.
That's absolutely okay.
Yeah. So today we'll have a discussion on steps of abdominal dissection. In this operative session in our class, we don't give a presentation on operative session. It's not a video presentation. It's an exam scenario. As the examiner keep on asking question on operative, we'll click on that. Okay. Dr. Shomen Das is with me. He's in charge of oncology unit at Netaji Subhash Cancer Hospital and ex-associate professor of surgery IPGMR SKM Hospital, Kolkata. So Srija Rai will present. Okay. So Dr. Shomen, you can study the indications of APR, which become more limited indications. Dr. Dash, please.
Yeah, thank you, sir. So, Dr. Srija, as I'm informed that you have not seen any APR, so that doesn't matter. You have heard of APR?
Yes, sir.
Okay. So, what is the full form of APR?
Abdominoperineal resection.
Okay. So, what are the indications of this operation?
Sir, if the anal sphincter is infiltrated by any tumor, then we have to excise the entire rectum and anus, including the sphincter. That is the indication of abdominoperineal resection. So we have to go both way from abdomen and from perineum. That's why it's called abdominoperineal resection.
So, this is a procedure by which you are going to remove the rectum and the whole of the anal canal
Yes.
along with the perianal skin, and
Yes.
it ends with a permanent stoma. So, that is abdominoperineal resection.
Yes, sir.
Why abdominoperineal? Because the approach is through abdomen and through
And
perineum.
also through perineum.
Right. So when you are asked to describe the indications, you should describe it in a systematic manner. That is, the malignant indications and the benign indications. Okay.
Okay.
So what are the benign indications? I'm coming to the malignant indications later. What are the benign indications of APR? Are they very pretty common, or they are very rare?
You see, our idea is to conserve
Why
sphincter.
indications? I don't know, sir.
Yes, see, so removing the rectum and anal canal will give a permanent damage to the patient, isn't it?
Yes.
So this should be the last weapon to fire, you know. So
Yes, sir.
this is not the primary treatment of choice for malignancy as well as the benign things. So in a
Okay.
patient where you have you heard of ulcerative colitis or Crohn's
Yes,
disease?
sir. Yes, sir.
So, in a patient where you have intractable Crohn's disease, where all the systemic therapies have failed and patient has dense disease in the rectum and anal canal. Okay, that may be the indication, benign indication of an APR in a case of intractable Crohn's disease. Okay, now coming to the malignancy group. In a patient where the sphincter is involved, rectal cancer, where sphincter is involved, or you are not able to get a sufficient margin if you plan a low anterior resection. So when we discuss APR or abdominoperineal resection, we need to be familiar with few other terms called anterior dissection, low anterior dissection. All right. So anterior dissection is when you are removing a part of rectum and keeping a sufficient margin distal to that. You should have at least 2 centimeter margin, and for low rectal cancers, if you can keep a 1 centimeter macroscopic margin and no tumor on the inked margin or in the donor, then it is sufficient, oncologically sufficient. Okay. But at times when the sphincter is involved, you cannot achieve a good margin there. That is an indication of abdominoperineal resection. Okay.
Okay, sir.
Fine. Okay. So next is after indication, what are the preoperative preparations for?
And most of these is, you have to say that it is always a distal rectal carcinoma. And in some cases of anal carcinomas, where most of the anal carcinoma respond to chemoradiation, but the residual tumor following this, then there is an indication for APR. What do you feel, Professor Shoman?
Yes, correct. So 3 indications. One is benign disease, intractable Crohn's. Number 2, rectal cancer, low rectal cancer with sphincter involvement. Or even if the sphincter is not involved, patient is having an incontinent sphincter. Okay. Low rectal cancer. How do you define low rectal cancer? What are low rectal cancers? See, rectum has got 3 parts, upper, mid, and low. These lower rectal cancer are defined as the cancers which are present within 5 centimeter of anal verge after doing a rigid proctoscopy. Okay. So if you do a rigid proctoscopy, you measure 5 centimeter, any tumor within that region is low rectal cancer. This is number 2 indication. Number 3 indications are squamous cell carcinoma of anal canal. Remember, the standard of treatment for anal canal cancer is chemoradiation following Nyclos regime. Okay. Now, there are some patients who will not respond to this Nyclos regime. So as a part of salvage surgery, you have to do APR in anal canal cancers. Am I clear?
Okay,
So these are 3 indications of APR in different scenario. Now, how do you prepare this patient? What are the preoperative preparations for APR?
Including counseling.
Yes.
Sir, preoperative preparations, if the patient can pass flatus or stool, then we have to go for colon preparation, and we will do preoperative monitoring of bloods, that is the routine blood tests, and pre-anesthetic checkup, including that chest X-ray, ECG, echocardiography, etc. We need one colonoscopy to be done to check if there is any more growth inside, and we need one CT abdomen to check for any metastasis elsewhere.
Okay, so if a de novo cancer, rectal cancer patient comes to you, de novo cancer patient, patient
Yes.
has not received any treatment prior to appearance in your OPD. So there, what are the things you look for? And when do you go ahead with, suppose it is a lower rectal cancer with sphincter involvement, okay? So when do you go ahead with APR upfront, and when do you put the patient on some neoadjuvant therapy?
Treatment of rectal cancer has changed. Okay, you have to assess preoperatively by clinical examination and MRI of the pelvis. Okay, so
Hmm.
what are the indication for neoadjuvant therapy in rectal cancer? Bulky growth,
Yes, sir.
and if you find that this patient has got a growth within 5 centimeter, is a well differentiated growth, still sphincter can be conserved if you give the patient neoadjuvant chemoradiation.
So
Okay, so you have to give it.
in case of bulky growth and in case it is within 5 centimeter
There
from
is,
the
there is,
anatomy.
there is pararectal involvement.
Yes, yes.
Okay.
Okay.
So before, see, once we describe any operation, as sir said, for examination purpose, there are some fixed headings on which we will be describing. But when we discuss rectal cancer management, you need to know certain more things. So when you describe any operation, the classical things are indication, preoperative preparation, then in anesthesia, incision, and steps of the operation. Lastly, the complication. So this is the format of describing any operation. But when we describe this rectal cancer, these allied questions will always be asked. Okay. So it is not that all low rectal cancers will go ahead with APR first. So you need to know something about called the investigations for rectal cancer management. So any rectal cancer should not undergo any treatment without an MRI. Good quality MRI. Okay. Why MRI is important? Because if in MRI you will get to know the T status or tumors, as sir said, whether it is a bulky tumor or it is a small tumor. So whether it is T1, T2, T3 or T4. Okay. Now, if the patient is having a T3 or T4 tumor or any node positive tumor in the mesorectum, so rectal cancer grows laterally. The beauty of these lower rectal cancers are they grow superiorly. That means they grow cranial. Okay. So the lateral spread is not that much. That is why the next concept of ISR or intersphincteric resection, we will come to that. First, let us finish off this abdominoperineal resection. So not all patients will undergo APR upfront. So there are some patients who are bulky tumors like T3 or T4 tumors or any node positive tumor. Or if the patient is having a lateral extension means this rectum is covered by a layer of fatty tissue along with lymph nodes. That is called mesorectum. Okay. So if the patient is having any lateral extension in the mesorectum, we call it mesorectal envelope or mesorectal fascia or MRF. If the MRF is threatened, that means the rectal cancer, when it grows laterally, it threatens or it gets involved with the mesorectal fascia. We call it MRF positive. So either direct extension or tumor extending up to 1 millimeter, within 1 millimeter of the MRF. Okay. So this is the scenario where the patient, if we do APR upfront or if we do surgery upfront, for that matter, not only APR, anterior dissection or any other rectal operation, then the outcome is poor. So it is better to give neoadjuvant chemoradiation in this group of patients and then to operate. Okay. So not all rectal cancers you will operate upfront. If the patient is having T3T4 growth, node positive disease, or patient is having a threatened MRF. Do you understand what is MRF and when we call it threatened? Either a direct involvement or a tumor going near the MRF within 1 millimeter of the MRF. Clear? So these are the indications when you put the patient on neoadjuvant chemoradiation. Clear? Now there are some situations where you can do upfront rectal cancer surgery. For
Okay.
lower rectal cancers, it is only the T1 and T2 tumors without any node involvement, without any MRF positivity. Okay.
Okay.
For upper rectal cancers, node negative disease, some T3, you can operate upfront. Am I clear? So
Okay,
these are all I'm talking about non-obstructing tumors. So rectal
Yes, sir.
cancer, they can present either with obstruction or without obstruction. If the patient presents with obstruction, the whole scenario changes. You need to take care of the obstruction first. Then you focus on this thing. And the patient has to be a non-metastatic disease. Okay. If the
Okay.
patient is having a metastasis in the liver, then the management protocol or plan again changes. So do you plan a curative surgery for a patient who is having liver metastasis in rectal cancer?
Sir, if there is obstruction, then we have to go for
Suppose patient is not obstructed. Patient is not obstructed. Patient is having a small 2 centimeter liver nodule at say segment 7.
What is the status now
We
regarding
can-
liver metastasis? Can you cure this patient? Single
No,
liver
sir.
metastasis, rectal or colonic cancer.
No, sir. We can do one diversion
No.
stoma.
Now there are a
You
lot of
can
newer
cure.
treatments.
You can cure. See, colorectal cancer with liver metastasis, if the liver metastasis is operable, then it is a curative scenario. Okay. So there, the protocol is different. First, you take care of the liver, then you take care of the rectum. So these are things. But I want you to know that colorectal liver metastasis can be a curative scenario. Am I
Okay,
clear?
Okay, sir.
So these are the situations where you put the patient on neoadjuvant chemoradiation therapy and the T1, T2 tumor with node negative disease without any MRF involvement, you can do upfront rectal cancer surgery, be
Okay,
it
sir.
anterior resection, be it abdominoperineal resection.
Okay,
Now,
sir.
classically, the difference between anterior resection and abdominoperineal resection is, in one case, you are preserving the rectal sphincter. In other case, you are removing the whole of the anal canal. Okay.
Yes, sir.
Now, how nutrition is important in preoperative preparation.
For any gut resection, nutrition is very important. Why? Srija,
In nutrition.
yeah.
Sir, after stoma formation, the patient will lose lot of water and electrolytes. For that, we need to maintain that beforehand.
See, for large bowel, it is not that key. There will be a lot of sodium, potassium, and electrolytes are going out. It's a scenario where you are dealing with a patient who is having malignancy and is supposed to undergo a major surgery. For any major surgery, the nutritional assessment, it has been seen the outcome of a patient who is nutritionally poor is always different. So assessment of nutrition of a patient preoperatively and taking care of the nutrition if the patient is undernourished is very important. Okay. So coming back to the preoperative preparation, how do you prepare gut? What is the standard of care for gut preparation?
Sir, we put the patient on a liquid diet for last 24 hours and after 12 hours prior, we give them colon preparation, this Peg or bowel prep, we give them with water, and the patient passes a lot of stool, and to replenish the water loss, then we give them ORS.
Okay. When do you admit the patient? On the day of surgery or before the day of surgery?
Before the day of surgery.
Before at least 24
24 hours
prior
before
to
the
surgery.
surgery.
Okay. One important thing for APR is a stoma marking and stoma related counseling.
Yes, sir.
This is not a thing which is, For other operations, we don't practice it regularly. But this is a mandatory thing nowadays. You need to counsel the patient beforehand because you are going to give him or her a
Permanent
permanent stoma. Okay.
Young
So
patient, how do you counsel? Just tell us
yes.
what you say to the patient. Why the patient need the surgery? How do you counsel? A lot of patient refuses, goes out. Tell us how you approach. These are now part of MABS student curriculum. You have to convince the patient to have a surgery where patient will go lifelong with a stoma. How do you start the discussion?
Sir, first I will
Tell us the
counsel
scenario, real
patient
scenario.
regarding,
You are discussing with the patient.
yes, sir. First, regarding the disease that he or she is having, the amplitude of the disease, and
What you tell? No, we're not talking of any theoretical part. What you tell to the patient to convince that yes, you need this surgery? How do you start?
স্যার আমি বলবো যে আপনার এই কোন
A lot of
অংশে
other people are there. Keep in English because a lot of
Okay.
other students are there in the.
Okay, sir. I
What do you
will
say?
tell that you have this malignant tumor or you have
So you
this
first study malignant tumor. Patient
no,
gets
sir, no, sir.
scared. He may
There may be
refuse.
benign indications also. You have this disease
No,
at
I'm
this
talking
part
malignant
of,
only. Malignant only. Don't start with the sentence that you got cancer, so you need the surgery. Start with very simple thing. You got a tumor in your rectum, which is more
rectum.
in the lower part, and for your cure, you need a surgery.
Yes, sir.
And how do you go? This is very
And
important part
I
of
will
discussion.
explain that the surgery can be curative for the patient, and the patient will need a permanent stoma. In that case, that is a different way for stool excretion, but that will help in saving his or her life.
He's saying that I don't want a stoma. Then how do you counsel? He said I don't want a stoma.
Uh, I will tell that there is so this procedure can help save his life, and the stoma care is
And?
nowadays much more
Yes.
convenient. There is
So
lot of
first you have to
stoma support.
explain. You have to explain that you understand that you got a tumor which is quite low in this your anal opening. So
Yes,
if you have to take that tumor out, you need a good margin so
Yes,
that
sir.
you don't have any problem in the local site. So to give a good surgical outcome,
Mhm.
to have a cure that you don't suffer with some tumor recurrence in the local site, you need to clear little more.
Okay,
And
sir.
now, as you said, there is no problem with the stoma. A lot of people are moving with the stoma. They are doing their job. They are taking part in sports. So it don't be a problem for you. So you have to convince that, first of all, you have to convince that surgery is necessary,
Necessary.
sacrificing the rectum anal canal. That is the first thing you have to explain.
Okay,
And
sir.
second is assure the patient that the stoma management has become easier. He can have a bath, apply the bag, go to the work whole day, he come back, and he can do all his activities. So that is the way you should go. This is a very important part of counseling.
Yes, sir.
Dr. Dash,
Right. Suppose I am the patient. I will tell you, okay, I'm not going to have a stoma. You tell me what are the other options, and if I undergo those options, then vis-a-vis APR, what are my downsides and what are the positive sides? So, do I have any other option other than undergoing APR? Nowadays, patients are, I mean, they always Google it. They will tell you, ma'am, I have heard of something called dostarlimab, which works very well. So can I take that drug? Will that be a curable one? Or I have heard of, suppose I have a T2 tumor, T2N0 tumor. You have offered me an APR. Now I am the patient. I am telling you, I have a rectal cancer. I have heard of something called watch and wait policy. So I want to undergo chemoradiation. Then I will not undergo any surgery. Am I eligible for that?
how do you counsel?
How do you counsel in this particular case?
Because you know the histology. You know the histology, you know the site, you know the behavior of this tumor in response to neoadjuvant. Some patient will definitely respond initially. So how do you counsel this patient?
So yes, tell me. Leave it. I'll tell you. See, this is a scenario. You need to have your backup knowledge adequate. Unless and until you know that, you won't be able to counsel the patient. Suppose the patient maybe a doctor comes to you. He might be a doctor also. So he will, I have personally have faced these questions. So see, you have a disease, which is a T2 cancer. T2 cancer giving neoadjuvant chemo. I told you, T1, T2, you can go ahead with upfront surgery. If it is T3 or T4, then only comes the role of radiation. So
Yes,
if
sir.
you have a T2 tumor, there is no role of giving neoadjuvant chemo radiation. Am I clear?
Okay, sir.
It is not advisable, or it is not a standard of practice to give neoadjuvant chemoradiation in a T2 cancer, T2N0 cancer. Okay. So if you are having a T3 or a node positive disease, we can go ahead with a neoadjuvant chemoradiation therapy. Then we will assess your response. If we find there is a complete clinical response, then only comes the role of wait and watch policy. This is called Haber-Gamma protocol. Okay. And there is something called total neoadjuvant treatment. I'm not going into that details. So there is a subset of patient where, but it has to be a T3 or T4 or a node positive disease or a mesorectal fossa involvement. So these are the candidates who will undergo neoadjuvant chemoradiation, and some of them will respond very well to this therapy. Okay. And some of them will have a complete clinical response. What is meant by complete clinical response? There is no evidence of tumor clinically by doing a parectal examination with proctoscopy, no evidence of tumor in MRI, no evidence of tumor in colonoscopy. Clear? So these are the subset of patients where you can follow watch and wait policy, but there you have to follow a rigid follow-up. Because this discussion you need to have at the very beginning. Patient might tell you at the end of the treatment course that you didn't tell me that I have to undergo MRI every two monthly. I would have undergone surgery. So these are the things you need to discuss at the very beginning. By two of my patients, they refused wait and watch when they were told that you have to undergo MRI very frequently, at least 4 or 5 MRIs in a year for next 2 years. So these are the situations, or these are the conditions which you need to follow if we undergo wait and watch policy. Okay. So otherwise, this stoma planning, this counseling is very important. The most of the centers, they have a stoma care nurse. So before you admit the patient, you need to mark the stoma site. Okay, you need to ask the patient to stand, see the bulge in the abdomen, because you at the time of anesthesia, under anesthesia, if you plan the stoma, so once the patient stands, it may be in some curvatures, so you cannot fix the back properly. So this marking of the stoma site prior to surgery is another mandatory thing for APR.
Okay, sir.
Okay.
Okay. So now discuss the steps.
Yes.
Yeah.
So any preoperative antibiotics and the steps. What anesthesia is given?
General anesthesia.
General anesthesia with endotracheal intubation. Correct. So what is the position of patient?
So position of patient is supine with head up, and the legs will be split
What is
to
that
assess
position
the
called as?
perineum.
What is that position called as? It's not typical lithotomy.
No.
It's called as Lloyd Davis position. Is leg up in a stirrup, but quite low. Okay.
Yes.
Okay, so that is the position of patient, Lloyd Davis position.
Yes, sir.
Okay. Though how do you drape these patients?
Sir, we
Which
drape
area you keep exposed for surgery?
Sir, Zifi sternum to mid thigh, we for both the legs we cover them with leggings, and above the Zifi sternum we cover with sheets, and the both sides we also cover with sheets.
Your answer should be
Below the
the
patient also.
yes, your answer should be the draping should be done in a way so that the abdominal part and perineal part remains exposed for surgery. Okay.
Is a male patient, you need to fix the scrotum. Is a
Yes.
male patient, need to fix the scrotum to the thigh or with some strapping, because otherwise scrotum will be hanging in front of the anal
Perineal.
orifice.
Yes.
Right. Now, what is the first step then?
So first we go through abdominal route. Incision, sir, midline incision above umbilicus to pubis, and then the then the rectum is mobilized.
No. First,
Wait.
first is exploration. Don't forget.
Yes.
Once a peritoneal cavity, you need to
Oh, yes,
explore.
yes.
What you explore on first go.
We have to see if there is any metastasis at any other part or
Where?
not,
Where?
at liver and peritoneum.
And
Yes.
momentum.
And momentum.
So first, ascites. So first,
Ascites,
assess the
yes.
distant metastasis, and then put your finger in the pelvis. What do you like to see? Sometimes you need to
There is any-
retract. You may not proceed that I'll do the surgery at the moment, because maybe the imaging was done earlier or imaging was not properly interpreted. So what do you
Yes, sir.
look at the growth in the pelvis?
So if it is resectable or not,
Yes. Yes. How do you decide that yes, the growth is resectable, I'll proceed? Because it's something in the anterior, something in the posterior, something on the lateral side.
there is if the growth is not adhered to the bladder or the vessels.
Which vessel? What is that posteriorly? Sacral
Sir,
hollow.
Sacral hollow, the bifurcation of aorta and IVC.
Bipedal is quite high up.
High.
Even the rectum it will come.
Oh, yes.
Okay. So most important is you assess whether the growth is fixed to the sacrum, whether it's breaching the presacral fascia. Anteriorly, male, female, it will vary. In female, it will be adherent to the vagina, but if simple adherent to the vagina is not a problem, you can resect vagina and do the procedure. But in male, if it is fixed to the prostate or the seminal vesicle, you should think whether you proceed or not. Okay. And then lateral pelvic wall. Lateral pelvic wall, it can be in front of the ureter or the vascular structures. Okay. So you first assess whether growth is resectable or not. Now, yes, you feel growth is resectable. So how do you proceed? There are salient steps in doing APR. You have decided you will proceed. Now, what is the first thing you do?
Sir, we need to mobilize the rectum.
No, you can't just jump to rectum. You start somewhere else. Where do you start the operation? The first step of the operation is you read the salient steps. First is mobilization of sigmoid colon, because that is the area through which you enter into the mesorectum. Where do you start now?
So from the white line of told, we have to give one incision, and
in sigmoid you find a white line of told. White line of told is found in the descending colon. Okay. In sigmoid colon you find the sigmoid mesocolon, which has got a right leaf, which is a left leaf.
Yes.
So you incise the sigmoid mesocolon, and then how do you go? Dr. Shuman, you have to keep on discussing, because she has not read well.
No, that's fine. That's okay. So the first step, what you do as sigmoid is a mobile structure, so most of the time sigmoid is a mobile structure. So you have to pack the abdomen. First thing you explore whether it is a non-metastatic disease, locally it is operable. before you put on your original surgical gloves, after anesthesia, first you do a parectal examination on table. Then you scrub and do an make an abdominal incision. So after you explore, the liver is free, there is no ascites, there is no peritoneal disease, the omentum is free. Locally, the growth looks mobile. But remember, for rectal cancer, when you are dealing with low rectal cancer, you should not see anything. Actually, the pelvis remains clean because it's a very low rectal growth. Ideally, you should not have any involvement of the bladder, any involvement, and you even if you try to feel the growth, you won't be able to palpate. So, okay, only you have a long growth. It is mid to low rectal growth, then only you will be able to feel it. Okay, so the next step is the mobilization of sigmoid colon. So most of the times the sigmoid remains mobile. You have to you have to pack the abdomen. Now there are few retractors which you need to know about. One is called the malleable retractor, which is a very good retractor to retract the small bowel and etc. towards the upper part. You need to pack the small bowel away from the field of vision. Okay. Then you your target should be you reach at the junction of the origin of the IMA. Okay, so that is your area of interest. So to do that, you need to retract the sigmoid colon in a way so that you make that area taut. So sometimes sigmoid colon remains adherent to the lateral pelvic wall. So you need to resect that part. I mean, dissect that part to make the sigmoid colon mobile and make it taut. So the next step is you incise the peritoneum. You incise the peritoneum or the mesentery at the mesocolon or at the area of sigmoid colon to expose the origin of the inferior mesenteric artery. Am I clear?
Okay, sir.
So this inferior mesenteric artery is your target. Now, one important point in APR and anterior resection is where to take the inferior mesenteric artery. Is it at the origin, or you can take it after the exit of the first sigmoidal branch? Do you understand what I mean to mean?
Yes, sir.
So
Yes, sir.
if this is the inferior mesenteric artery, it will give the first sigmoid branch like this, and this branch will go downwards, which becomes the superior rectal artery. Okay.
Yes, sir.
So where do you clip or where do you ligate? At the origin or after the exit of first sigmoidal branch?
Sir, after the
left colic branch.
Left colic branch.
Sir, after the exit of left colic branch.
Yes, see, so the previous concept was you need to ligate it at the origin. Now what is saying that even if you ligate it after the exit of the branch, if you take care of the lymph nodes around the root of IMA, then it is sufficient. Okay, so this will serve two purposes. One is the viability of your stoma, sigmoid colon, the part of resection. You are basically resecting at the mid of the sigmoid. You may not need to take the whole of the sigmoid with the specimen, mid of the sigmoid or in the proximal sigmoid. So there, this vascularity remains intact. And number two, it helps since you are taking the lymph nodes along the inferior mesenteric artery, the oncological purpose is also served. Okay, then what next? So you have identified the inferior mesenteric artery, you have dissected the lymph nodes along with it. After the exit of branch, then you have ligated it.
Yes, sir.
And this is the concept you understand. You have not handled the tumor. You are first taking the vascular pedicle. That is the concept of oncological surgery. Before you handle the tumor, you take the inframesenteric artery and also find the inframesenteric vein. What do you find? Do you find the artery vein together? Is inframesenteric vein and artery lying close side by side?
I don't know, sir.
It's not exactly side by side. Inframesenteric vein goes up and it drains where? Inframesenteric vein drains where?
Inferior mesenteric vein
Drains into?
drains into splenic vein.
Yes. So you dissect and try to ligate the inframesenteric vein higher up so that you get a good mobilization. Higher up, close to the pancreas.
Okay, sir.
So usually inferior mesenteric vessel, once you make it taut, the artery remains like this, but the vein remains flat. Okay. So after you take care of the artery, you will identify the vein going up. So you to get a good mobilization, you identify the lower border of pancreas. There it is going inside and meeting with draining into the splenic vein. You can ligate it there. Okay. So you get a good lymph nodal harvest as well as a good mobilization. So
Okay.
inferior mesenteric artery and vein taken care of. What next? So
You
now
will be dissecting the whole rectum and anal canal. How do you go? Posterior dissection, lateral dissection, anterior dissection. So how do you take the posterior dissection? Where do you incise and what precaution you take as you go down?
So we have to identify the ureter and preserve the ureter.
when you are doing this IMA pedicle, you have the right-sided ureter is already you have seen, because
Yes.
when we are making the peritoneum taut, the right ureter is usually visible. When you are taking care of the inferior mesenteric artery on the opposite side, you have
Yes.
to safeguard the ureter. Okay, so ureter is already taken care of at the time of IMA dissection. After that, the whole idea of rectal resection or anal canal resection is something called the holy plane. Okay. The Bill Hild, who popularized this concept of going into this avascular plane, where the concept is you need to take a good oncological control and you need to safeguard the neural plexus around the rectum. Now, how the nerves are distributed and how the fascia is distributed around the rectum. If you understand that, then your dissection plane, be it anterior dissection, be it posterior dissection or lateral dissection, will be clear. Okay. So rectum, if you talk about the peritoneum, see the upper and middle part anteriorly having peritoneum. Then this peritoneum and the pouch of Douglas goes above. In case of females, it will cover the vagina and then it will go up in the bladder. In case of males, what will happen? It will cover up the prostate and seminal vesicles, then it goes in the bladder. The posteriorly, the rectum laterally, the first part, only the upper part is having peritoneum. The rest is extraperitoneum. Okay. So we have dissected this peritoneum. IMA and IMB pedicles are taken care of. Then the posterior dissection starts. Here, once you do the posterior dissection, you need to enter in a plane called holy plane of the rectum, where it is a plane basically between the sacrum and anteriorly you have mesorectum. So there is a beautiful plane, usually avascular plane. Now remember, there is a fascia called Waldeyer's fascia. And this fascia lies at the level of sacral S4 level. This connects the presacral fascia with the mesorectal fascia. So unless and until you make a sharp cut in the Waldeyer's fascia, you won't be able to enter into that plane. Okay. So there is a fascia called Waldeyer fascia. You need to cut it. You need to retract the rectum anteriorly with retractor, and you cut this fascia with diathermy or with a pair of cold scissors. Then you enter into the holy plane of rectum, and then it becomes very easy. Even without any cautery, you can dissect this plane, and just by retracting the rectum, you can reach up to the right up to the lower part. That means the levator ani muscle. Okay. One important area is preventing the damage to the neural structures or nerves, autonomic nervous system there lying there. Okay. What are the areas where the nerves are usually damaged? You see, there are two neural plexus, autonomic neural plexus you need to take care of. One is superior hypoglossal plexus. Another one is inferior or pelvic hypogastric plexus. The first one originates superiorly, okay, in the para-aortic area. The first area where you can damage them is at the level of inferior mesenteric artery. So if we transect the inferior mesenteric artery very close to the aorta, then there is a chance of damaging that sympathetic plexus. Now, what will happen if we damage the superior hypogastric plexus? It's a sympathetic or parasympathetic one?
Parasympathetic comes from where? In the pelvis? Which sacral segment? S2, 3, 4. So it will parasympathetic will be lower down in the pelvis.
So the upper part is sympathetic, parasympathetic is lower.
Okay,
So
sir.
if you damage the sympathetic, so as a whole, if you damage the both, what will happen? There will be a lot of things. There will be urinary issues. There will be ejaculation issues. Okay.
Yes, sir.
So if we remove the sympathetic one, bladder will undergo in a tonic position. Okay.
Okay, sir.
There will be a continuous tonic position. If we remove the parasympathetic one, then what will happen? Bladder will not be able to contract, but the sphincter will remain in contracted position. Okay. So these things, plus there is something called larvae erigentis, which will create problem in erection and ejaculation and all this. Okay. So these are the functions. These, especially if the patient is male, young aged, he has to have a good quality of life later on. So this preventing the damage to the sympathetic as well as parasympathetic plexus is very important. So first area where you damage is in the at the root of IMA. The second area is at the lateral pedicles, okay, where it crosses the ureter and goes downwards towards the neck of the bladder. Okay. Third area is at the levator complex. Because you are doing APR, you will cut the levator. Okay. So these are the areas where you need to take care of the nerve plexus. Okay. So this posterior dissection, so by doing a sharp diathermy dissection, after cutting the Waldear's fascia, you can reach right up to the levator muscle. So posterior dissection is not that difficult, it is complete. Then comes the anterior dissection. How do you do anterior dissection? Suppose it's a male patient.
Then it should be lateral. After posterior should be lateral
It
dissection.
should be lateral, then comes the anterior.
Laterally, what do you get? If you try dissecting sharply laterally, some structure comes and that need to be taken care of and divided. What attach the rectum to the lateral pelvic wall? There is a ligament. First is the mesorectum, and then as you go down, you find the lateral ligament of the rectum, through which a vessel may run. Which vessel? Middle rectal vessels. Okay. So if you are using harmonic, you can easily go through this lateral ligament by dividing. Okay. Otherwise, you need to ligate and divide. So do it either side. How do you do the anterior dissection? Suppose in male and female it's different. Describe in male, what do you get? Anteriorly, you have a layer of peritoneum going from the rectum to the bladder in male. Seminal vesicles. How do you go with the anterior dissection? What is the step for anterior dissection?
So like the posterior one, in anterior, you have something called denonvillar fossa.
Yes, sir.
So what do you go? In which place? It's a peritoneum. It's peritoneum covering the anterior rectum, then going superiorly, anterosuperiorly covering the bladder. After it covers the prostate and yeah. So where do you cut? You make an incision close to where? See, by this time, your posterior and lateral dissection are complete. Once you have a peritoneum attached between the, in case of males, bladder, the seminal vesicle and the rectum. In case of females, you have vagina anteriorly and the rectum posteriorly. So this peritoneum, you have to make a sharp cut in the peritoneum at the pouch of Douglas. And you need to take care of the denonvillar fossa. You go in the plane between denonvillar fossa and mesorectum. Okay. So that is the area of dissection. Ideally, if your MRI was done properly, so you are able to find that the plane is not involved, so you can get away with the dissection in this area. Okay. So here it is a deep pelvis. You need to have a good retractor to retract the in females the vagina anteriorly, and in males the seminal vesicle and the prostate anteriorly, and you go in the plane between the denonvillar fossa and the mesorectum. Okay.
Okay, sir.
Then how far you go? This dissection from anterior aspect or through abdomen, how far you go? You can reach up to, there is something called levator ani muscle. Okay. So
Yes, sir.
after you reach the levator ani muscle, how do you identify levator ani muscle? Both anteriorly and posteriorly, when you are dissecting, you will find some striated muscle, or you will find some muscular structure coming around the tongue. That is the levator ani.
Yes,
Then
sir.
you stop. Then you stop your dissection from anterior abdominal wall.
Yes, sir.
When
And
the perineal surgeon start working, it's a abdominoperineal dissection. When you ask the perineal surgeon to start working, at what stage?
Sir, after reaching the levator ani muscle, then
He can start earlier. You see,
Yes.
once you decided that if the growth is mobile, you are going to dissect. Once you done the posterior and lateral dissection, because
Yes,
you have gone up to the tip of coccyx. Beyond that, you have anacoccygeal raphe. That is better divided from below. Okay, so once you decided, then the perineal side. So up to this is the abdominal dissection. Now you're in the perineum. How do you proceed? You are now in the perineum. How do you do the perineal dissection?
sir, incision is given around the
Before
anal.
incision, before incision,
Before incision, PR is done.
here you have already done. Now the patient is in Lloyd Davis position. You have an open anus. Suppose you try to make an incision, what will happen? There will be spillage of stool.
Yes, sir.
So what you need to do? You need to apply a purse string suture around the
Yes.
anus.
Around the anus.
Secure that area so that the spillage doesn't happen. Okay.
Okay, sir. Okay, sir.
So that is the first thing. You make a purse string suture. Then
Then an perianal incision is given.
classically described as what? It's a elliptical
Ma-
incision. Elliptical
Elliptical.
incision around the anus.
Okay, sir.
Okay, and then you deepen the incision. So as you deepen, what structures comes on either side, anterior, posterior? What is the outermost muscle you come across in the perineum?
So,
Yes,
so sphincters we are removing, we'll find the levator ani.
liver is little higher up. So as you go deeper, the outermost sphincter is the external sphincter.
External sphincter.
Yeah. So you go around, you go
Around.
circumferentially.
Yes,
And
sir.
first you go posterior. Posterior is easier. As you go posterior, dividing the anacoccygeal raphe, you can
Yes.
meet the abdominal surgeon.
Yes, sir.
Okay. So
Okay, sir.
first go posterior.
Really.
And if the abdominal surgeon has gone far off, maybe abdominal surgeon has divided the lateral ligament. So you are almost through. So you have to divide the sphincter muscles laterally.
Yes, sir.
And then from the perineum, you can divide the levator. Or abdominal surgeon can divide. If you are doing laparoscopically, the laparoscopic surgeon can go almost beyond the levator ani by dividing from above. Okay. If you're not done, you have to do from the perineal side. And the anterior decision is important. In APR, the anterior decision is important. Why? What you come? Suppose you are doing in male. What is they are just in front of anal canal.
The urethra and then there is prostate.
Prostate will not come at the age. Prostate is little higher up. The urethra is important. So you have catheter in the urethra also. So that is your guide.
Okay,
So now you dissect,
saving the urethra.
taking care not to injure the urethra. And if the abdominal surgeon has done the dissection up to the tip of the prostate, then if you dissect anteriorly, dividing the Walder fascia, perineal fascia, you are through in the abdomen. So idea is to the abdominal surgeon and perineal surgeon should meet on all sides, and the specimen should be free.
Okay, sir.
Then next is what step? Now abdominal surgeon start working more.
Yes,
What?
at the midway of sigmoid, we have to divide and clamp, and then the stoma side. Then we have to take that out from the stoma side.
Usually take the specimen out to the perineum.
Perineum.
Then closure. Some
So,
closure has to be done from the perineal side.
yes, the closer. Yes, the perineal side is closed in. So levator ani muscle will be closed, then the subcutaneous fat will be closed, and then the skin will be closed.
We prepare drain.
We'll put a drain in abdomen.
In the perineum also, you can put a drain, and if this if you close the peritoneum in the pelvis, then you need to put two drains. And if the cavity is connected, then only one drain will do.
Okay, sir.
Then regarding the transection of the sigmoid, you can do it before this perineal surgeon starts working. Once you finish up you want to decide that you are committed, because
Yes,
that has got one advantage. If you dissect, transect the sigmoid colon beforehand, the vascularity and viability of the future stoma will be visible by that time. So it is
Okay,
10-15 minutes will be over. So you can see
Yes.
that viability. Okay. And
Yes,
the
sir.
stoma side you have already marked. Through
Yes,
that
sir.
side, you need to make an end stoma. Okay.
Okay, sir. Okay,
So
sir.
hemostasis is to be achieved adequately. The pelvis is to be cleared of any blood or clots, etc. Put a drain and then you close. Simultaneous abdominal and perineal closure is done. Okay.
Okay, sir.
Now, what are the
We have gone beyond 9.
Oh, okay. So you need to know the complications. That
Yes, sir.
completes your thing. And in this regard, just 2 words on one thing is called ELAP, extralevator abdominoperineal excision. So there you have tumors. This once you do this APR, there will be a coning of specimen at the level of levator ani. So it will be like this specimen. But
Yes,
if you have a tumor at the anorectal junction, which
Yes,
has
sir.
got a lateral extension, you might have to take this levator ani. So there will be a cylindrical specimen. That is called ELAP or extralevator abdominoperineal resection. This is
Okay, sir.
extended APR. And there is something called ISR, intersphincteric resection. So these are smaller resection through the internal and external intersphincteric groove. In between the external and internal sphincter, you make an circular incision in the intraluminal part, not outside. In the you feel the intersphincteric junction, make an circular incision, then you go in the plane between internal and external sphincter. So these are recent advances. One is the when you have advanced, you go for ELAP. When it is smaller, you go for intersphincteric resection, and you give a patient non-permanent stoma.
Okay, sir.
Okay.
Yes. Thank you, Sija.
Thank you.
Thank you so much, sir. Sorry, sir. I'm extremely sorry. I missed.
Okay. Just you have discussion, because exam is, these are things you need to know: indications, pre-op preparations, then salient steps. And in steps, don't make a paragraph. In steps, you make headings: mobilization of sigmoid colon, incision of the sigmoid mesocolon, ligation of inflammatory artery, posterior dissection, lateral dissection, anterior dissection, and then the perineal part. So if you divide into salient steps, you can describe properly.
Okay, sir. Okay, sir.
Okay.
Thank you.
Thank you so much. Thank you so much, sir.
Thank you.
একটু সকালবেলা এসেছিল 99 সকালবেলা জল দিয়েছিল এটা কি নিচে তুমি নিয়ে কেন বলতে তো আমার বাড়িতে আছে নিয়ে এসে যখন খুলেছে আপনি বলতেন যে আমি এটা নেবেন আমার বাড়িতে আছে কাউকে বললে আনিয়ে দেবো তাহলেই আনিয়ে দিতে পারবো যতবার ভর্তি হবে তাহলে দেবে কিছু করার নেই হ্যাঁ না হলে হয়তো একদিন হয়তো এমনি নেবে তারপরে কাউকে বললে কারো হাত দিয়ে পাঠালেও হবে সঙ্গে করেছি কিন্তু নিজে
40 হয়েছে দিদু ও দিদু দিদু আবার 40 হয়েছে 40 পায়খানা হ্যাঁ একবারই হয়েছে
এখন
কালকে রাত্রিবেলাতে যে একটা জিনিস খেতে দিয়েছিল সন্ধ্যাবেলাতে খেয়েছিলেন তো সেটার পরে আবার 40 হয়েছে কালকে দুবার হয়েছে রাতে কালকে রাতে দুবার আজকে সকালে একবার দিদি এই পেশেন্ট কতবার 40 করেছে জানেন বেগলেকের পরে দুবার আর একবার তো
ওখানেই লেখা আছে একটু বেশি করি সবাই
2 times 2 pass
এটা এক এখানে করেছে 2-3 বার
টোটাল 3 বার তো
হ্যাঁ একসাথে পায়
কার্ডিও মেডিসিনের লোক আমি জানি না এইসব বেশি দাও কিন্তু না আজকে সকালে আমার জ্বর এসেছিল কিটা একটা অবধি হয়নি হ্যাঁ